If there is atherosclerosis, a patient have a risk of atherosclerosis, a risk of heart disease, a history of any atrial fibrillation, a history of any endocarditis, a history of valvular lesion, it is probably due to ischemic stroke, that is embolic type. If the patient have a history of smoking, diabetic mellitus, and mostly it occurs in men, that is due to ischemic, that is embolic strokes. If the patient have a history of drug intake like amphetamine, cocaine, and bleeding disorder, it can be due to subarachnoid hemorrhage. And if there is a history of trauma, it can be due to subarachnoid hemorrhage. If the patients have hypertension risk, trauma, bleeding, use of drugs, illicit drugs, leads us to intracerebral hemorrhages. The clinical onset of or the clinical presentation of ischemic stroke. When you see these presentations, there is a weakness, which can be hemiparalysis, which can be monoparalysis, which can be quadriparalysis, and there is also a coordination and loss of balance, and there is also a sensory loss, that may be primary sensory and that may be cortical sensory, and there is oculomotor and visual disturbance like conjugate horizontal eye movement, like transient monocular blindness, and there may be a headache, and there may be a behavioral change, confusion, there may be impairment of memory, neglect, speech problem, aphasia, dizziness, and seizure can be a clinical presentation. This can be a clinical presentation for a patient who have ischemic stroke. To localize this ischemic stroke, we must identify the arterial territory. That means there is anterior cerebral artery, there is middle cerebral artery, and there is posterior cerebral artery. So the anterior cerebral artery supplies the portion of the motor and sensory cortex that's related to the contralateral leg and bladder. That means the inhibitory and the micturition center in the bladder. So anterior cerebral artery supplies these portions, that means the leg and the bladder. If the patient is presented with more weakness on the leg, and if the patient presents with incontinency, the anterior cerebral artery is affected, or there is a thrombosis, or there is an ischemia on the anterior cerebral artery, which is on the medial part of the brain. The middle cerebral arteries also supplies the lateral surface of the cerebral hemisphere. It supplies the lateral surface of our brain hemisphere, and it supplies the motor and sensory cortex that are related to face, hand, and arm. That's contralateral. That is the right side supplies the left side. The left side supplies the right side. So the expressive or Broca's area and wrinkles area, that's language areas, are also supplied by this middle cerebral artery, and also visual cortex and basal ganglia also supplied by the middle cerebral artery. So if the patient is present with difficulty of speech, difficulty of analyzing language, difficulty of vision, and contralateral weakness on the face, hand, and arm, and even in the legs, but it is more on the arms. It is the affected territory, the middle cerebral artery, that supplies the lateral surface of the brain. So the lateral surface of the brain is affected if the patient is presented like these scenarios. And if it is posterior cerebral artery, the posterior cerebral artery mainly supplies the posterior medial aspect of the cerebral hemisphere. That means the brainstem, the thalamus, and the cerebellum. So if in coordination problem, If there is a coordination problem, that's balance problems, mostly the posterior cerebral artery is affected. Knowing this supply of the brain or arterial supply of the brain is important to localize which part of the brain is affected. Is that the medial part, is that the lateral part, or is that the posterior medial aspect of the cerebral hemisphere is affected? To know this, the arterial supply is important. Let's say about some points about the transit ischemic attack. The risk of stroke after transit ischemic attack is around 10 to 50% in the first 3 months, which is mostly occurs in the first 2 days. The risk can be directly estimated using the well-validated ABCD square methods. According to this ABCD square score method, the risk of stroke after transit ischemic attack will increase as the score increases. For example, if the ABCD score is out of 7, if it is 7, if the score is 7, there is 22%, around 22% of the occurrence of a stroke after within 3 months. When we see these clinical parameters, that's the score methods, A means the age that's greater than or is equal to 65 years. If the patient is age is greater than or is equal to 65 years, we score 1. If the blood pressure is greater than 140 by 90 millimeter of mercury, we score 1. And the clinical signs is the clinical signs. If it is unilateral weakness, we give 2. If there is a speech disturbance without weakness, we give 1. Then the D is duration. If it is greater than 60 minutes, we give 2. The score is 2. If it is between 10 to 59 minutes, the score is 1. If the patient is day patient, or if he is on oral medication or insulin, we give 1, and we add that. If it is 0, the total score is 0, there is no risk within 3 months. That means there is no stroke after transit ischemic attack if it is 0. If it is 2, if it is 1, the probability of being stroke is 2%. As I said, if it is the score is 7, the probability of transit ischemic attack changes to stroke within 3 months is 22%. There are some clinical classification of stroke other than this. The first one is transit ischemic attack. The second one is evolving stroke. The third one is complete stroke. And the fourth one is minor stroke. These are the classification other than the main. These are the clinical classification of the stroke. When you say evolving stroke, when signs and symptoms of stroke worsens gradually over a period of hours or days, that leads to a stepwise increase in focal neurological deficit, that's known as evolving stroke. When you say complete stroke, is when stroke evolves rapidly over a few minutes and reaches to maximum disability within hours or 2, within 1 hour or 2, and the signs and symptoms that lasts 24 hours. When you say minor stroke, is when the patient recovers without a significant neurological signs and symptoms within 1 week. For clinical features, middle cerebral artery stroke that can cause hemiplegia, that means face and arm is greater than leg on the contralateral side, and there is also hemisensory loss, that's contralateral, and there is also homonymous hemiplegia, that means bilaterally, and which is symmetric loss of vision on the half of the visual field, and there is also aphasia, that's loss of speech if dominant hemisphere is involved, and hemi-neglect if the non-dominant hemisphere is affected. On the anterior cerebral artery stroke, there is a hemiparesis and cortical sensory loss on the leg greater than face and arm on the contralateral sides, and there is a urinary incontinence to failure to inhibit the reflex of bladder contraction. If it is vertebral arterial stroke, there is a hemenopia and cortical blindness, and there may be amencia, and there may be thalamic pain, maybe occur. So this is all about the ischemic stroke. Let's use a hemorrhagic stroke. It accounts around 50 to 20% in developed countries, and much more in developing countries. The incidence increased. Mainly, it is associated with unrecognized or poorly controlled hypertension. The causes are, it can be hypertension, it can be head trauma, it can be ruptured cerebral aneurysm or arteriovenous malformations. It can be due to systemic coagulopathy, it can be due to anticoagulant therapy, it can be due to drug abuse like cocaine, amphetamine, it can be hemorrhagic infraction, that means the transformation of prior ischemic infraction. It can be due to metastatic brain tumor, it can be due to age related also. So this hemorrhagic stroke can be intraparenchymal or cerebral hemorrhage that accounts around 10%, and subarachnoid hemorrhage that accounts around 8 to 10% of all strokes. So the intracranial or intracerebral or intraparenchymal hemorrhage is caused by the rupture of the microaneurysms that develops typically in patients with hypertension. The most common site of bleeding are the basal ganglia, the pons, and the cerebellum are the most sites of the bleeding sites for intraparenchymal or cerebral hemorrhage. The clinical manifestation will be usually it occurs suddenly when the patient awake from the awake often during activity. It's abrupt onset of severe headache, that is focal neurological deficits, which worsens steadily over 30 to 90 minutes. But the subarachnoid hemorrhage, it is spontaneous rather than traumatic, and it is arterial bleeding into the subarachnoid space. There is a collection of arterial blood in the subarachnoid due to the subarachnoid hemorrhage that results from the rupture of berry or circular aneurysm, which is one of the major cerebral arteries or their branches at the circle of wheels. And the clinical manifestation for subarachnoid hemorrhage, it often occurs during exertion. That means during straining, sexual intercourse, or sexual activities. And the sign and symptoms are associated with intracranial hemorrhage and with meningeal irritations. There may be headache, which is severe, radiating to the occipital region. There may be a vomiting, loss of consciousness following headache, and neck stiffness, photophobia, tonic-clonic seizure may be occur occasionally, and retinal hemorrhage and papilloedema may be seen on fundoscopy. And focal neurological signs are due to the compression of the nearby central nervous system by clot. There may be a visual field defect due to cranial nerve 2 compression, and there may be ocular movement disturbance due to cranial nerve 3, 4, and 6 compressions, and there may be a hemiparesis. There may be hemiparesis may be also occur. with stroke. The first one is the stabilization and initial assessment. The second one is determining the presumptive diagnosis of stroke subtypes, thus based on history and physical examination. The third one is confirming of the diagnosis, that is whether it is stroke or stroke mimicry. And the fourth goal is management of strokes based on specific or based on the types of stroke. So let's start from the first approach. The first approach is stabilization and initial assessments. That means we rule out other causes. Other causes must be ruled out because stroke is a medical emergency and it needs a maintenance of vital functions as necessary. So we must rule out other causes of or the mimicries of the stroke, and we follow the ABCD of life. That means we maintain the airway and the ventilation and the circulation. Then we control the blood pressure. If the BP is greater than 220 over by 120, we give short-acting antihypertensive medications to control the hypertensive effect. We can give the labetalol or nicardipine. This nicardipine and labetalol are the drug of choice. If the patient is hypotensive, the patient may be stroke and they may have present with hypotensive. So fluid expansion and treatment of the underlying cause may be necessary. So identifying and treating the underlying cause is important here. And the patient may be present with fever, so controlling the body temperature is also important. The patient may be present with dehydration, so fluid management may be important. So during the first goal or the first approach, that is stabilization and initiation of assessment, we rule out other causes or mimicry of stroke, then we act accordingly. This is the first phase. That means the initial assessment, and we secure the ABCD of life of the patient. That means the airway, breathing, and circulation must be maintained at this stage. The second is determine the presumptive diagnosis of stroke subtypes. That's from the history and the physical examination. That means we ask the mode of onset and the progression pattern. As we discussed previously, if it is embolism, that occurs suddenly when the patient is awake, mostly in the early morning, giving a maximum deficit at the onset. If it is thrombosis, it often occurs during sleep time or present upon arising from the bed. It is a progressive in a stepwise manner, which is a stuttering type. And if it is hemorrhagic stroke, the progression is minutes with hour. It is progressive. It's progressive. It's progress minute to hour. And in hemorrhagic stroke, the patient is mostly present with loss of consciousness is there. But on ischemic stroke, there may not be loss of consciousness. So first we ask the mode of onset and the progression pattern to identify which type of stroke is there. Then we ask the prior history of transient ischemic attack, and also we assess the thrombotic vascular diseases. Is there any disease? Is there any vascular disease? Is there any medication intake? Is there any prior transischemic attack? Because transischemic attack have a chance of transforming to a stroke within 3 months. More than around 22% of or 10 to 50% of transischemic attack can be transformed to stroke. So asking this is important. Then we assess sign and symptoms. The sign and symptoms of increased ICP. If there is a sign and symptoms of ICP is there, it's probably hemorrhagic stroke. If there is headache with loss of consciousness without major neurological deficit, it suggests a subarachnoid hemorrhage. One thing here, in subarachnoid hemorrhage, there may not be neurological deficit, but in ischemic stroke, there is neurological deficit that occurs maximal at the onset, and there is no loss of consciousness on ischemic stroke unless it transforms to hemorrhagic stroke. Then we assess fever.